So welcome to this week's podcast by GPs for GPs at all stages of their training. My name is Dr. Susie Scarlett. I'm a GP in Edinburgh and I'm a GP trainer. I also have an interest in diabetes, and I'm here with Dr. Callum Leese this week to discuss all things cardiovascular medicine with our guest speaker. The aim of this podcast is to provide CPD for primary care staff around physical activity, to inspire primary care staff to take up more physical activity and promote this to their patients, to educate the listeners in the latest knowledge, current guidelines, national and local opportunities and further resources and education, and to transform primary care. Callum.
Thanks, Susie. I'm Callum. I'm a GP trainee in Aberfeldy and a researcher at the University of Dundee. In this episode, we're going to be interviewing Dr. Edney Boston-Griffiths, who's a cardiologist with an interest in lifestyle medicine. He did his undergrad at Barts in London, an MD at UCL also in London, and a fellowship in interventional cardiology in Canada. He's currently an interventional cardiology consultant in Dorset and has got his own practice combining traditional care with lifestyle to improve cardiac health. Welcome, Edney.
Thank you, Callum. Thank you, Susie, for inviting me to this, what I'm sure will be a wonderful podcast. As you've mentioned, I'm based here at Dorset. I work at Dorset County Hospital. I'm an interventional cardiologist, and I've been based here for about 3 years now. I did my training at within the East of England Deanery, and since starting practicing here in Dorset, I've grown to learn that we're dealing with a slightly an aging demographic. However, they have got a longer lifespan compared to the national average. So they tend to be healthier, they've retired here, and they've got a relatively higher standard of living. So it's been exciting to work within this part of the world.
Edney, tell me, how did you end up interested in lifestyle medicine?
Well, I've always been interested in fitness, exercise, you may say well-being and healthy living as part of my personal life journey. My exercise involves resistance training, endurance. In fact, I've ran a couple of half marathons, including the London Half Marathon, and I'm into yoga. I try to, do that, at least once or twice a week. I also do martial arts as well. I do Wing Chun, which is a Chinese martial arts, and I've been doing this since starting medical school. So in and around my lifestyle, I've always had a passion for being active. Certainly when I practice medicine, I do see patients with obviously the severer, more complex cases of coronary artery disease. I'll treat them with pharmacology or procedure-based treatments with stenting. And they've always asked me, what do I do now, doctor? You've done this treatment. Where do I go from here? And I've always sort of made a reference to my lifestyle in terms of, foods to eat, being active. And it was great to find the British Society of Lifestyle Medicine, which obviously provides an evidence base when it comes to these strategies and way of living. So that's what really got me into looking at the BSLM a bit further, and now I'm in a position whereby made my way through the online learning, and the idea is at some point get into the diploma level. So certainly I find it very beneficial, and I think that's where medicine is going in terms of combining conventional strategies with lifestyle medicine and preventative care. I think there's going to be a space whereby they should really go hand in hand, and obviously the education from BSLM has highlighted that space.
I think a lot of the evidence came from the godfathers of lifestyle medicine across in the States, didn't it, as well? And, in a previous podcast that I recorded with Dr. Emma Loonan, we were talking about physical activity and chronic disease, that it could, all could benefit from physical activity. And this is where lots of this evidence lies. I think the problem that we have and we're sort of working against is that, media sometimes misrepresent some of the studies that are done, and the studies are done to help us, but then they get misrepresented. Callum and I were talking about the recent media messaging on the association between daily step count and all-cause cardiovascular mortality. This fantastic meta-analysis, but they twisted things on their head and they said 4,000 steps is enough. That's all you need to do. What's your comment on that?
No, again, I think this is certainly a space whereby we as health professionals should really lead up on that, in order to at least attenuate some of the sort of the media experts who may, misguide the message. I think it's long been established that you need to do 150 minutes per week of exercise, and that's moderate exercise, or as high as 75 minutes of more high intensity exercise, if we want to be in a position whereby we're seeing the cardiovascular benefits long term. Um, and we can go from, and I'm sure we're going to go at some point down in the podcast to talk about how this impacts on cardiovascular risk factors like hypertension and dyslipidemia. But I think certainly we have to be leaders in this space, not only to define what we mean by exercise in terms of the physiology, but also the recommendations and the prescribing of exercise to our patients, because it shouldn't be taken lightly. Whilst we know that um, it's unequivocal that exercise is beneficial, we have to consider certain special cases, like patients who already have pre-existing high blood pressure. Certainly it needs us as healthcare professionals to lead and direct patients with valve disease. So I think, we have to ensure that the message is clear with patients. It's not just whatever they see in the media. They need to use us as a source of direction.
I totally agree, Edney. I think that's really important. That paper in particular by Bannock et al., which Susie was talking about, the take-home message in the paper itself is really clear, which is more exercise is better, but some is better than none. And I think actually that's a really good policy for us as healthcare professionals to hold. If people ask us how much should we do, we should say, the more you do, the better, but some is better than none.
No, no, absolutely. And again, when we look at the data in terms of not only managing the blood pressure, but when you talk about end organ damage, when you talk about the changes that happened within the heart as a result of, for example, high blood pressure, we know that certainly walking the dog is much better than being inactive, but also high intensity is better than just moderately walking the dog. So there is a gradual effect when it comes to exercise. But you're absolutely right. Certainly, some is certainly better than nothing at all.
I think, Susie, I maybe steal your sandwiches a bit here. This is something you always mention. I love it. There's the WHO Every Move Counts, which is a publication that they released, I think it was in 2018, but they got this great graph which shows that the benefits are greater the more inactive you are. And so I think that's really helpful to bear in mind. If you do nothing, you've got the most to gain from doing something, regardless of what that is.
And I understand you're obviously based in Copenhagen. Do you find that there are differences in terms of, the level of inactivity here in the UK compared to maybe our counterparts in Europe?
Good question. I'm back in the UK now. But
okay, back in the UK.
Yeah, definitely. I think one of the things which was amazing about Denmark and probably Northern Europe in general was the infrastructure that was there to facilitate activity, and particularly around cycling. I think it was almost hard not to cycle in Denmark. It was just everywhere. So I think that was the big difference is that people, when we talk about physical activity or exercise, I think people often think, oh, it's me adding an extra 20 minutes into my day. Whereas in Denmark, it was just replacing your drive with a cycle. It was a form of commuting. And I think that was really, really kind of interesting insight and hopefully something that we can copy and echo and learn from here.
Absolutely, absolutely.
Callum, I'm a big advocate for the active commute, as you'll know, and I think the planning agencies up and down the United Kingdom have got something to answer for, haven't they, in terms of making physical activity accessible. But today we wanted to talk to you, Edney, about how we can manage high cholesterol and high blood pressure. When people say to us that they want to manage without medications, but what does this look like?
My philosophy, and I think that it concurs with that of the experts, is when it comes to cardiovascular risk, we have to look at it in its entirety. You as GPs, you have the Q risk score, which obviously looks at a wide range of risk factors before deciding to initiate a patient on medication. And I think that is certainly a good starting point. I think one can't really take an isolated high cholesterol without looking at the fact that whether or not they're diabetic or not, or whether or not they have high blood pressure or the family history, or whether they're a smoker, because certainly those obviously play an impact. If we take blood pressure in its isolation, I think certainly exercise alone has a role for stage 1 hypertension. So, for example, a patient otherwise free of any other cardiovascular risk, you see them in your clinic and they have a systolic blood pressure just over 140 over 90, then I think introducing exercise or prescribing exercise as a first stage, whilst obviously addressing other lifestyle factors, could be a good starting point. Once you get to a point, and this is what was clear on the evidence, certainly presented within the conference, once you're about 150 over 95, then you really want to get the blood pressure controlled first, pharmacologically, then introduce exercise as a prescription. So that's when you would be taking them hand in hand, both pharmacological and non-pharmacological strategies for managing that particular risk factor.
There's a few things I totally want to pick up on there. I thought, first of all, we could maybe do a deep dive into cholesterol and then hypertension.
Sure.
I think that's something I'd definitely love to revisit later on and remind us if we don't, is that cutoff, you said 150 over 95, that sounds like something we should definitely talk about.
Yeah.
One of the reasons that I really wanted to talk to you in the podcast is that, countless times with people coming through the door with high cholesterol, high blood pressure, and often it's quite hard to know how to give them specific advice. I find this particularly with cholesterol. I think a lot of the evidence says that actually dietary cholesterol, or the evidence I've read, it might be wrong, that dietary cholesterol doesn't have a huge impact on our blood cholesterol. And so I'm left in this limbo, being like, I don't really know what the best advice to give for cholesterol is. And maybe I've thrown you the deep end here, but are you able to talk us through how you advise people managing their cholesterol with lifestyle?
Well, I think it's a good point. I mean, generally speaking, what I do, sort of, which is not necessarily evidence based, but I do tend to focus on the saturated fat. So once I've seen a patient who's come in, they've got coronary disease, you've treated them either pharmacologically or with stents, and they want to know what they can do in terms of their diet, in terms of minimizing or reducing the risk for further events. I do address their consumption of saturated fat, in particular processed meat. So I do emphasize personally that they should avoid processed meat from their diet. It tends to be very high in salt. It tends to be high in saturated fat. And I think that there is evidence to suggest that that impacts on cardiovascular events in the future. And we've seen that from observational studies where you take huge populations whereby their consumption of saturated fat is low. They're predominantly vegetarian, particularly in the US. You have the seven church evangelist communities, and you see that they tend to live longer. They tend to not really encounter much in the way of cardiovascular disease. So certainly from that observational data, we know that is reasonable advice. So when it comes to the numbers then, when I see them, again, from a secondary prevention perspective, I want to drive their cholesterol down pharmacologically, less than a total cholesterol of less than 3.8 and the LDL less than 1.8. Again, the evidence is robust. The lower the LDL, the better. So I suppose secondary prevention is a different beast. I think in that context, there is no argument that pharmacological intervention with statins and potentially with other lipid-lowering medication, like your inclisiran, PCSK9 inhibition, bempedoic acid, are required. In the primary setting, there's some evidence that, generally speaking, you want the total cholesterol to be less than 4.6. But again, one must pay attention to the ratio. So it's your ratio. You really want to look at the subgroups. You want to look at your LDL, and that LDL, it's safe if it's less than 2.6. Okay, so if you do your check your cholesterol in your patient, their total cholesterol is less than 4.6, LDL is less than 2.6, then you may be okay, provided that they don't have any other cardiovascular risk factors. Then you can start talking about dietary intervention and focuses on that. However, if the LDL is above 2.6, you do your Q risk score is above 10%, then you have to start thinking about introducing statins, particularly if there are other additional risk factors, diabetes, etc. Is that helpful?
Yeah, I think so. And I think one of the things that I've Peter Attia, I don't know if anyone's come across him, but he's an American metabolic specialist who's written a book and podcast series, and he's actually surprisingly a big advocate for lifestyle medicine, but often in conjunction with statins. So I think that's helpful that statins aren't necessarily the enemy. I have a few things I wanted to pick up on, and this is a podcast about physical activity, and I will come to that. But first of all, you mentioned processed meats, and I think, Joe, in a really helpful way, that's getting a lot of attention at the moment about the harms of processed meat. I try and be vegetarian, often not great at it at times. I describe myself as a vegetarian without a moral compass. But what about dairy? I love cheese, and I find that I'm probably not the only one that, as I try to eat veggie, my cheese consumption goes up. What's your advice on dairy intake and cholesterol?
Well, and I think that is with most people. I think when you do take in one of the food groups from your diet completely, I mean, I'm certainly advocating for removing processed meat. I think we can certainly do without that. But when you start taking certainly certain food groups from the diet, you tend to increase in other areas. So I think dairy, I think for taste, in moderation, I think that can be compromised. But I think it is a challenge when it is flavorsome, and you can add it sparingly to foods, to salads, to encourage you to eat, to consume that in a moderate way. But I think it is challenging to start removing too much too soon from the diet. So I will never be sort of harsh on that. I mean, I've switched for milk. I've switched to oat milk and almond milk. So I think the family have moved towards that now. So that works really well. The children love cheese. I'll have it sparingly, but it's not something that I can't live without. But I think you gotta see how you fit in and see what works for you. But I wouldn't be too, like you said, without a moral I wouldn't be too harsh on yourself in this regard.
Well, thank you. Susie, quick question.
Yeah, the irony is not lost on me that my consulting room, if I have my blinds up, looks directly onto a well-known bakery. So occasionally I'm having these lifestyle discussions about cutting out processed meats with my lovely Scottish patients, and in wafts the smell of bacon butties. I mean, it's just awful. You couldn't make it up. Oh, and next door to that, there's the funeral, the funeral place as well. So
Ideal location.
Pulling it onto the thing that I'm certainly passionate about, physical activity. What role does physical activity have in cholesterol management?
Again, I mean, it's difficult. I think when I do think about physical activity and lifestyle, I've not thought about it in the isolated risk factors. I look at it sort of in encompassing your overall cardiovascular risk. So I certainly think that physical activity, irrespective of what your cholesterol level is going to be beneficial for you. So I think once you've identified that patient with high cholesterol or the Q risk that you're concerned about, then you're down the line of thinking about them engaging in a physical activity that potentially hopefully they're going to enjoy themselves. So you can start having that conversation with them. I always start off with, what is it that they enjoy doing? Or I make the assumption that they exercise, and I ask them what their main form of exercise is. And then you have a starting point from which to build upon. So for example, very commonly within my demographic, It's usually walking the dog as a main form of exercise. So we then start to build from there, making sure, are they doing it on a daily basis? Are they doing it in a duration that you may find acceptable? And then you can start encouraging the role of resistance exercise, but that's very important. So they should be walking at least 3 to 5 times per week for endurance, and then resistance maybe 2 to 3 times a week. And then you start adding in balance with your yoga, tai chi, qigong. So I have that sort of stepwise approach to building up for that sort of optimal exercise regime.
Oh, that's really helpful. There's just a few things I wanted to mention. And first of all, I love the idea of assuming that people do something because it's super non-confrontational. I think that's really helpful. I think often we're taught never to assume anything, but sometimes saying, "Oh, what kind of exercise do you like to do?" It is a helpful non-confrontational way of approaching things.
Yeah.
I'd like to know what Susie's thoughts are on that, but.
I was just thinking that I assume all my patients are not moving from their chairs very often. So that's where you and I differ. But, we're meeting our patients where they are and we're nudging them forward.
Absolutely. Again, it's like you said, it's a demographic thing. I mean, being in this part of the world, I find myself encouraged to go for walks, go for runs, spend time outdoors as much as possible. So yeah. So it tends to work. And if they don't do any exercise, they are forthcoming with that, and then we can start and build from there. Absolutely.
I think that the other thing I just want to pick up on was partly the resistance training, but also the aerobic element. I think that they're both backbones of what we should be advising. One of the things I often find tricky is, I tell patients, well, the advice is 150 minutes of aerobic exercise a week. And I think that's almost a meaningless statistic that I churn out. And so I think breaking it down into 5 30-minute dog walks with a steep hill that you get out of breath on is helpful. I think also introducing the resistance element's really important, and we'll come on to that in the hypertension discussion just after this. But I pulled out just before the talk some of the American Heart Association statements on cholesterol, and they've got a few things or statistics from 2021 where they say aerobic exercise is helpful at increasing HDL by and also dropping triglycerides, but resistance training is the best form of exercise for dropping LDL. So it's quite helpful. It also interestingly said that smoking cessation increases HDL, but doesn't have an impact on LDL. And diet has a limited effect on cholesterol as well.
I think you're right. I think whilst addressing the biochemistry with the lipid profile, ultimately you have to take the patients in context. So you have to look at what is their BMI. Do you need to encourage them for weight management therapy? So for them to be active or addressing their diet. And I think, again, you also have to look at, their food choices. Is it related to stress? Is it related to poor sleep? Is there a metabolic syndrome involvement? So you're absolutely right. You have to take all the other factors that may have an effect on those levels. And I think, one thing I learned yesterday in my talk is when you do have that high cholesterol profile, don't forget to check the renal function. Don't forget to check the thyroid function, because what you don't want to be caught out is a situation whereby, you're treating the biochemistry in isolation without considering other drivers for that number. And then you have that separate beast, which is the familial hypercholesteremia. And tackling that would be slightly different as well. So you're absolutely right. You have to take all these things into context. But that's very interesting in terms of the effect of dietary changes, exercise on the subunits of the lipid profile, which you've taught me something today. Certainly.
I think you're right, and I'm probably trying to oversimplify this. It's such a holistic picture that exercise and lifestyle has an impact across all our health and well-being, and my brain often tries to oversimplify that. The biggest thing that came out of that reading that I did was that the biggest thing consistent across all forms of cholesterol and triglyceride was weight loss. And if people lose weight, their LDL falls, their HDL goes up, and their triglycerides fall as well. And so encouraging weight loss is really important. And obviously that's multifactorial, but physical activity has a role in that.
No, absolutely. And the key thing when it comes to, I mean, this is probably something that we'll probably talk about, but what are your thoughts about the GLP-1 agonists and how that can drive down weight in the absence of physical activity? That may be something that maybe leave for another discussion, but I just thought that now you mention it, what your thoughts are on that for both of you, actually.
There is an absolutely brilliant Lancet article that was written by the BSLM Vice President Ellen Fallows, together with Varun Anand and one other person, and I apologise that I can't remember their name, but I haven't met them personally, whereas the other two I have, which addresses that very thing, where, yes, they are fantastic with their outcomes, but unless we're addressing the driving factors, as soon as you take away the medication, the problem comes back. But you're right, that is a whole podcast on its own, and possibly out with the physical activity movement prescription podcast, but definitely one I would love to talk to you offline about, Edney, at some stage. But let's focus now on hypertension, because we see so much high blood pressure, especially where I work, in a very deprived area where people get sicker quicker and lots of it at the same time, lots of multimorbidity, constantly dealing with high blood pressure. So in terms of physical activity, what role does that have in people with high blood pressure?
Well, I mean, you're absolutely right, Susie. We know high blood pressure or hypertension is certainly a common problem. 1 in 3 people over the age of 50 have hypertension, and out of that, we know that certainly from a secondary care perspective, 20 to 40% of them already have end organ involvement or end organ damage. So it's certainly a challenge. And as I mentioned before, when I do see these patients in secondary care, usually it's for those who are maybe a little bit more challenging, a bit more resistant. So my strategy is always to number one, exclude any secondary causes. So they do go through echocardiograms, renal profile, albumin creatinine ratio, CT scans looking for coarctation and other causes of secondary hypertension. They get the echo to primarily exclude any end organ damage. I may, consider cardiac MRI scans if necessary, and ultimately, in some cases, I even think about whether or not there's a role to exclude coronary disease. So these patients are complex and they warrant that thorough investigation. And I think it is important because, like mentioned before, certainly if the blood pressure meets stage 1 hypertension, then there is a role to prescribe physical activity as a first line therapy. And we know from a large meta-analysis that physical activity, aerobic exercise after about 4 months can drop your systolic blood pressure down by 10 millimeters mercury, diastolic down by 8 millimeters mercury, and a tablet can, a losartan or one of the sartans, essentially can drop it down to about 6 millimeters mercury. So we know that physical activity can have a role within that stage 1 hypertension. Once you get to the point of blood pressure systolic 150/95, as mentioned before, then I think what you want to do is introduce pharmacotherapy first, get that stabilized, and then introduce physical activity. So certainly there is that would be how I would address and combine those two strategies.
And I learned something very interesting this week. In our local diabetes newsletter, I was doing a spotlight on sleep this month. And one of my local sort of enthusiasts was telling me about the link between obstructive sleep apnea and treatment-resistant hypertension. And it's a huge link and underappreciated, I think, and certainly in primary care. Is that something that you come across a lot as well?
No, I mean, that's certainly something I take into consideration because, like I said, when I see patients in an outpatient setting, I do a comprehensive lifestyle medicine clocking. So I ask them about diet, exercise, weight management, sleep, and stress. So I hope within that context, I'm able to tease out, the quality of their sleep, and then consider whether or not they need to be sent for a sleep study to my respiratory colleagues to exclude obstructive sleep apnea. Because I know that, when you have these periods of um, um, hypocapnia or acapnia during sleep, that can drive your sympathetic nervous system and drive your adrenergic surge and ultimately increase systemic resistance and as a result, increase in blood pressure. So I think it is something that definitely we know about the mechanism. It's something we should really screen for to ensure that we get to the bottom of the drivers for high blood pressure.
Callum was looking at some papers. I think he was going to comment on those now.
Yeah, I think you alluded to it, Edney, actually. A paper just from last month by Edwards et al., which was a huge RCT of over 270 papers. It was really interesting. Basically analysed the different forms of exercise and what were the best at dropping blood pressure. The bottom line, I think, is that all exercise was beneficial in terms of treating blood pressure. Aerobic was actually the least beneficial, and the most beneficial was isometric exercise. So I really like the outcome is really quite clear. It's worth checking out. But the thing that struck me the most about the outcome is that isometric resistance training is really great for all age groups because it doesn't require weights or really any movement. So we're talking about wall squats, planks, and other static forms of exercise. So I think those type of things are great for kind of cross age and cross generation. So yeah, I think that's a really cool outcome, which is wall squats and planks.
I think, and if you look at some of the more recent data, I mean, there was the Copenhagen Heart Study that looked at. It was published in the Hypertension in 2020, and it looked at patients who have LVH, so left ventricular hypertrophy, versus a group of patients with no evidence of left ventricular hypertrophy. And follow them over time in terms of their cardiovascular events. And he found that actually, in moderate to high intensity exercise was much more beneficial compared to mild exercise like walking, and obviously compared to inactivity. So there is data coming out now whereby they, isolating the role of resistance or high intensity exercise, which falls into the line potentially of CrossFit. So I do CrossFit once a week, and I think that's probably the obviously it's the ideal, but that's what you want to aim for, because it incorporates both, like you said, isometric body weight exercises as well as the more weightlifting and then your shorter endurance exercises. So I think that really encompasses an ideal program. Go on, Susan.
I've put my hand up there because I've got alarm bells going off in my head. As a frontline GP who sees some fairly unhealthy Scottish folk, I'm worried that if I suggest HIIT to some of them, high intensity training, they're going to drop dead with a heart attack, which would be going against everything I first do no harm.
Do no harm, absolutely. Do no harm. This is not for the average. But you always want to know what the ideal is, right? You want to have something to aim for.
Susie, I totally agree. And how do we meet people where they're at? And resources, especially around this field of resistance training and balance, can be really hard to find. There's a few good places to check out. Versus Arthritis has got some resources, and Age UK's got some resources as well, just to guide people towards. Susie, I think you'd also highlighted some to me previously too, but my memory is a sieve, so apologies.
Oh, resources for GPs. The Motivate to Move resources are fantastic, and the moving medicine conversations with patients, they've got them for all the conditions. And I also love teaching the medical students. There's the Faculty for Sports and Exercise Medicine have got exercise on prescription for all the chronic diseases, including cardiovascular disease. So, if you're somebody that teaches medical students, GP trainees, and actually quite relevant for us as well at this stage, I think that's a brilliant resource that can be looked at.
Sure.
One of the big take homes I want to just bring out here is that there's more and more evidence coming out about the importance of resistance training as part of our overall health. There was a paper, again, there's been so much coming out recently, but just from a few weeks ago, that basically it looked at people's adherence to WHO guidelines for physical activity. Usually that's just done for the 150 minutes a week, and we say about a third of people are inactive. But they included the 2 resistance sessions per week that's recommended, and only 17% of adults or 13.5% of older adults were achieving the guidelines. And so it's certainly something that we can focus on and work on, and certainly something that we should be looking to advise patients to do. Again, within the remit of what they can do, as opposed to sending them to the nearest CrossFit class.
No. I mean, I think you're right, and I think that's when we have to collaborate with our cardiac rehab experts. I mean, these they're experts in terms of determining the intensity of exercise based on the premorbid state of patients. So I think that is also a very useful resource in terms of experts. They're able to use the Borg scale, doing functional capacity assessments before engaging in exercise, and I think that's very useful. They will consider other comorbidities, atrial fibrillation, hypertension, and sort of gauge the exercise strategies based on that. So I think that in my certainly my private practice, I work very closely with a cardiac rehab fitness expert to help obviously my more vulnerable clients.
And Callum, I know that here in local to us, we've got our local leisure facilities have got trained physical trainers who work with people getting back to fitness. And I think, once you know about these resources in your community, utilize them. I think our role is not necessarily to hold our patient's hand and take them. I think it is about giving them the evidence, those brief interventions, isn't it? And sort of, people listen to what their doctors say. There's enough evidence out there to show that the patients listen to what we say.
Yeah, I agree. And one of the things I highlighted in as a question was, how do we involve other healthcare services in delivering a holistic approach? One of the things that's so inspiring about talking to you, Edney, is that as a secondary care provider, you're also really engaged in lifestyle medicine. And I think that approach, if it's heard from throughout the healthcare journey, people are more likely to engage. There's loads of resources out there. Susie, you mentioned some of the local kind of local gym and leisure providers. Anything else you'd recommend, Edney, to people to engage?
Well, I mean, like I said, I've accepted that the challenge of really lifestyle intervention and changing behavior and the direction of huge population bases, it's not something that can be done in isolation. I think as health professionals, I've realized that actually once I've initiated therapy and treatment, I need a collaborative effort from my colleagues, dietitian, cardiac fitness experts, psychologists, mind-body experts, because what I feel that is important, and I think the gold standard, is providing that comprehensive, holistic approach to cardiovascular health and well-being. So that's what led me to set up my my lifestyle medicine program. Is the My New Self program. It's called My New Self. You can see it in my website, and essentially it just involves 6 experts who we all work collaboratively and would deliver lifestyle medicine and preventative care holistically to clients virtually. So I think that's the really key message, is realizing that it can be difficult to find in the right experts, whether you go to a fitness establishment or a gym, or you go to a local service within your area. What clients want, is to find all these experts in one-stop shop to deliver the services that they need.
I'm going to just pull out the just kind of, we've been going a while and towards the end, but there's one thing I wanted to bring up, and I didn't forewarn you about this, Edney, so I'm sorry, but one of the concerns I've heard regarding exercise, particularly in people with cardiovascular disease, is safety. And what advice do we give to patients to say, look, not only is this safe for you to do, but this is both beneficial and life improving. And also on the same side of the coin, how do we get that message to family members? Because I think family members are often the key here, because they can either be super supportive and engage and really help and facilitate people being more active. On the flip side of that, they could be slightly paternalistic and overly protective and say, no, you're not doing that because you've had a heart attack. So yeah, what advice can we give, and how do we engage the wider family and community?
Well, I think it's an excellent question, and I think again it's education, motivation, and inspiration. I think in the first instance, again, turning to our cardiac rehab colleagues, when a patient has had a heart attack, which is at the point where they're most vulnerable and they've been treated, we have facilities to engage them within 72 hours into a cardiac rehab program, where you have these expert nurses that will talk to them firstly through their medication, make sure they're tolerating it well, but then can devise a program that would be a step-by-step program to get them to the level that they were once achieving. And that is the safest environment in which they can start building that confidence and be reassured that, it is safe to exercise. So I think once the exercise certainly is supervised, they are involved in the building of that program, I think that will be the first steps to getting them back to what we consider to be an active lifestyle. And I think that's why I talk about psychology, because it may not necessarily be that they're physically incapable of doing it, but once they've faced whether it's a cardiac arrest or a significant heart attack, then psychologically that's had an impact on them. And what you then need is cognitive behavioral therapists or exercise behavioral psychologists to help to unpick some of the barriers to exercise that may be limiting patients in engaging. So I think it is a multidisciplinary approach, really, to get to the crux of these challenges.
And in primary care, we don't always have access to all of these things, and often have to, as the last surviving generalists, do a lot of this ourselves. So, a lot of what we do in our primary care, hopefully before they get to you, Edney, is try and help people to see what's possible, to understand the benefits of even just doing little things like standing up in the commercial break when they're watching telly, breaking down that sedentary behaviour, avoiding what we refer to as the weekend warrior effect. So even GPs sitting on their bottoms for 9 hours in a day and then doing a half marathon at the weekend, actually that's still sedentary behaviour during the week, and you can't undo that with your weekends. But it's helping people see what's possible, building it in, using those teachable moments, I think, and providing the right support.
I agree. And Edney, you talked about the psychological element and having to engage people where they're at. And I think often as GPs, you feel underprepared and ill-equipped with which to do that. We talked about it briefly last time, and actually to kind of try and address that, particularly in the physical activity space, we've done some interviews with Dr. Hamish Reid on motivational interviewing, and also an interview with Naomi Molnar, who's a behavioral scientist, which were both really fascinating and hopefully give a bit of an insight into tips and hints and tricks with which to kind of help people and engage them where they're at and encourage them to be successful in making changes.
Sure, that's fantastic. And I mean, in your practices, how easy is it to access, like you said, the behavioral scientists and cognitive behavioral therapists? I mean, is there sort of a signposting that you can do for patients who you feel may need that, or like you said, you have to do it all on your own? Is that right?
Welcome to general practice, Edney. There's very little resource for that sort of.
Yeah, totally. I've not really experienced that. I think certainly if people have depression or anxiety, there's cognitive behavioral therapy available, and often that's delivered online by online platforms. I've not seen any out with that, and particularly not in the realms of lifestyle medicine. And so it's left to us.
Yeah, absolutely. Yeah.
Just as we draw to a close, Edney, any key resources that you'd recommend people to have a look at or check out? I've got the nice guidelines, and we'll stick them up in the show notes for when the podcast is is released. But is there anything else that you'd recommend?
I mean, if you really, interested certainly from a cardiology perspective, there is sports cardiology. So the ESC have a section on sports cardiology, which certainly gives you some insight in terms of cardiac exercise physiology and cardiac rehabilitation. The European Society of Preventative Care, or European Association of Preventative Cardiology, that they have an annual conference, which next one is going to be in April next year, 2024, and that will be held in Athens. So again, that's where I resource information with regards to implementing preventative care into my daily practice. So I think those are the big sides. So yeah, you can find lots of useful information within the ESC, and like I said, the European Association of Preventative Cardiology, they have a conference which is in Athens next year. So that's another port of call.
Just the ESC, the European Sports Council, European Sport Cardiologies.
The European Society of Cardiology. So the ESC, the European Society of Cardiology, and within that you have the sub task forces or sub societies, and one being the preventative cardiology. Yeah.
Perfect. Thank you. How about you, Susie? Any resources to recommend?
Well, I think I recommended some earlier on, but I'm just thinking, right, how am I going to work in some prescriptions for planks and wall squats next week? That's my plan.
Absolutely. No, I think give it a go. I think honestly, it sounds challenging, but I think that patients have to start somewhere. We all do. When I started my first CrossFit class, I was last in the group. And you've got to start somewhere. And then the key thing, really, I think, is consistency. Is putting the egos aside, deciding that this is the lifestyle pathway that you want to embark on, and then just be consistent with it. And it's amazing how people start seeing improvements in something that they felt that they could never do, and all of a sudden, now they're hugely engaged in it. So I would. It's like I said, it sounds sort of far to reach, but I think you would be amazed as to the achievements that you can see in a few weeks.
I think that's a really cool place to finish, Edney. The take home of consistency to kind of go alongside moderation of what we eat and also exercise, that more is better, some is better than none.
Absolutely.
I've really enjoyed the conversation. It's been really great. And thank you so much for joining us. And hopefully we can kind of continue it and then see where it leads.
No, absolutely.
Yeah, thank you so much.